প্রিয় মেডিকেল শিক্ষার্থী ও চিকিৎসকবৃন্দ, আসসালামু আলাইকুম। আশা করি সবাই সুস্থ আছেন। জেনেসিস অনলাইন ইউনিভার্সিটির পক্ষ থেকে চমকপ্রদ সেশন নিয়ে আসছেন ডাক্তার সমাজের অহংকার, আমাদের গর্ব, বাংলাদেশ নিউরোমেডিসিন বিভাগের উজ্জ্বল নক্ষত্র, শহীদ সোহরাওয়ার্দী মেডিকেল কলেজের জনপ্রিয়, স্বনামধন্য এবং শ্রদ্ধেয় অ্যাসোসিয়েট প্রফেসর ডক্টর ইব্রাহিম খলিল স্যার। স্যার অসাধারণ ক্লাস নেন। আশা করি আপনারা শুরু থেকে শেষ পর্যন্ত স্যারের ক্লাসের সাথে থাকবেন এবং কোনো কোয়েরি থাকলে অবশ্যই আমাদের কমেন্ট সেকশনে গিয়ে কমেন্ট করে জানাবেন। ধন্যবাদ।
থ্যাংক ইউ আমাকে ইন্ট্রোডিউস করা দেওয়ার জন্য এবং এই ক্লাসে আমন্ত্রণ জানার জন্য। I feel proud to be here today, and now I'm going to share my screen. Let's start. Today we'll learn regarding motor neuron disease. I'm Dr. Mohammad Ibrahim Khalil, Associate Professor, Department of Neurology, Shaheed Sohrawardy Medical College. British scientist Stephen Hawking, one of the leading scientists in this century and the last century, he was with the disease, motor neuron disease, ALS, Amyotrophic Lateral Sclerosis. Motor neuron disease, group of disease which include progressive degeneration and loss of motor neurons of the brain and spinal cord and replacement of the lost cells with gliosis. There are upper motor neuron lesions and there are lower motor neuron lesions and combinations of the upper motor neuron and lower motor neuron. And this combination of the upper motor neuron and lower motor neuron is called amyotrophic lateral sclerosis. And this is the most common variety. And in case of lower motor neurons, there may be involvement in the limbs that is called progressive muscular atrophy. And if it involves the bulbar region, this is called the progressive bulbar palsy. If it is upper motor neuron lesions in the limbs, it is primary lateral sclerosis, which is called PLS. And if it involves the bulbar regions, this is called progressive pseudobulbar palsy. And usually anyone may be present or maybe combination may be present, like that it may be present with upper motor features only or maybe features of lower motor or sometimes maybe combination of the both. But the most of the time usually one feature is present and subsequently all feature ultimately goes to the amyotrophic lateral sclerosis. So we know that this is the lower motor neuron, anterior horn cell or their homologous cells in the cranial nerve nebulae with their axon and up to the effector organ. This is the lower motor neuron. Okay, and the upper motor neurons, we know the pyramidal cells in the cerebral cortex with their axon up to anterior horn cell or in the cells in the brainstem in cranial nerve nuclei. This is called the upper motor neuron. So this is the cell body and up to these portions and the anterior horn cell of the spinal cord. This is upper motor neuron, and from the anterior horn cell to up to the effector organ, this is the lower motor neuron. Again, this is the upper motor neuron and this is lower motor neuron. This is upper motor neuron, and from cranial nerve nuclei up to effector organ, this is lower motor neuron. Again, this is upper motor neuron and this is the lower motor neuron. So there are some features we can differentiate whether it is upper motor neuron lesions or it is lower motor neuron lesions. In case of upper motor neuron lesions, there will be spastic paralysis, and in case of lower motor neuron, there will be flaccid paralysis. And in case of atrophy, in lower motor neuron lesions, we found severe atrophy. And in case of upper motor neuron lesions, there is usually no atrophy, but sometimes we found some sort of atrophy. This is called diffuse atrophy. Okay, and then there may be fasciculation and fibrillations. In case of lower motor neuron lesion, there may be fasciculations, but in case of upper motor neuron, there is no fasciculation. And deep tendon reflex, in case of lower motor neurons, the deep tendon reflex will be diminished or absent, but in case of upper motor neuron, it will be increased or exaggerated. And pathological reflexes, especially Babinski signs or plantar extensor in case of upper motor neuron lesions, but in lower motor neuron, it will be absent or flexor. And superficial reflex are absent in case of upper motor neuron, but present in case of lower motor neuron lesion. So these are the features we can differentiate whether it is upper motor neuron lesions or lower motor neuron lesions. So motor neuron disease, MND, there is progressive wasting and weakening of all the muscles in the body, usually after the age of 40 years. The risk significantly raises. MND is most likely to appear between the age of 55 and 75 years. Usually no in MND. There are some features usually not present in case of motor neuron disease. Right? No sensory impairment, no bowel and bladder impairment, no cerebellar impairment, no extraocular muscle impairment, and no definite sensory level. So we always think these are no in case of motor neuron disease. So এই ফিচার্স গুলা motor neuron disease থাকবে না usually. Causes and risk factors, the exact cause are unclear, but some genetic, toxic, viral, and other environmental factors likely to play a role. Some MNDs are inherited while others happen randomly. Pathology. In case of ALS, it is characterized by motor neuron degeneration and death with gliosis replacing lost neuron. Cortical motor cells, pyramidal and bad cell, disappear, leading to retrograde axonal loss and gliosis in the corticospinal tract. These glioses result in bilateral white matter changes, sometimes seen in the brain MRI. The spinal cord become atrophic and ultimately affected muscles show denervation atrophy. Pathogenesis. Abnormalities in the supraoxide dismutase gene account for about 20% of such cases. But recently, there are some chromosomal associated with MNT in the frontotemporal dementia. Pattern of involvement. আমরা আগেই বলে আসছি, there are most of the case there are 5 pattern of involvement. This is progressive muscular atrophy, progressive bulbar palsy, pseudobulbar palsy, primary lateral sclerosis, and amyotrophic lateral sclerosis. So these are 5. Sometimes many teachers and many books are mentioned 4 types except primary lateral pseudobulbar palsy, but in most of the books it is 5 types. So progressive muscular predominantly spinal motor neuron gula affected হয়, weakness and worsening of the distal limb muscles at first. Distal limb muscles গুলাতে first এটা start হয় and fasciculations usually present থাকে and tendon reflex may be diminished or absent. So this is progressive muscular atrophy, PMA. And progressive bulbar palsy, early involvement of the tongue, palate, and pharyngeal muscles, and there will be dysarthria and or dysphagia, worsening and fasciculation of tongue, and sometimes associated pyramidal signs may be present. That is plantar extensor and deep tendon reflex exaggerated may be present associated with this feature. So this is a tongue, this is wasted, the worsening of the tongue here, tongue wasted. আমরা যদি fasciculation দেখি এই ভিডিওতে, let's see the fasciculation in the tongue. These are the fasciculation in the tongue. Yes, these are the fasciculation in the tongue. Okay, now pseudobulbar palsy. Pseudobulbar palsy shares some common symptoms of progressive bulbar palsy and characterized by degenerations of the upper motor neuron that transmit signal to the lower motor neuron in the brainstem, and progressive loss of ability to speak, chew, and swallowing, and progressive weakness in the facial muscles and expressionless faces may develop gravelly voice and an increased gag reflexes. Tongue may become immobile and unable to protrude from the mouth, and this is the classical called hot 42 speech. Yes, an individual may have outbursts of laughing or crying due to central involvement of emotional involvement. So there are bulbar palsy and there are pseudobulbar palsy. We can differentiate how we can differentiate bulbar from pseudobulbar palsy. In case of bulbar palsy, bilateral lower motor neuron defect থাকে of cranial nerve 9 to 12 cranial nerve. That is dysphagia থাকবে, more liquid than solid. Nasal regurgitation on slurred speech, nasal speech, wasted tongue with fasciculation and absent gag reflex. These are the features for bulbar palsy. On the contrary, in the pseudobulbar palsy, bilateral upper motor neuron lesions in the 9 to 12 cranial nerve, dysphagia, dysarthria, emotional lability, slow indistinct speech, spastic tongue, Briggs Georgia, and frontal release sign. Sometimes we may press. So these are the pseudobulbar and bulbar palsy. Now come to the primary lateral sclerosis, that is called PLS. It is upper motor neuron syndrome, rare disorder. Usually survival range is good, even years to decade. Even with normal lifestyle, weakness is typically distal and asymmetrical. Patient present with slow progressive spastic paralysis or bulbar palsy. EMG তে electromyography যদি আমরা করি, there is no evidence of, because this is upper motor neuron syndrome. And now come to the amyotrophic lateral sclerosis. This is the most common presentations and combinations of the distal and proximal muscle, wasting, weakness, and fasciculation. Spasticity present, exaggerated reflexes, extensor plantar, bulbar and pseudobulbar palsy may be present, and pyramidal tract features may predominate. So there is a combination of the upper motor neuron features and lower motor neuron features in case of amyotrophic lateral sclerosis, ALS, and this is most common. So amyotrophic lateral sclerosis. Amyotrophic means no muscles nourishment. Lateral refer to the area in the person's spinal cord where portions of the nerve cells that signal and control the muscles are located, and sclerosis means scarring of the affected nerve. So this is amyotrophic lateral sclerosis, and there is a diagnostic track: ALS, upper motor neuron features, lower motor neuron features, and progression. So if we found there is upper motor neuron sign and lower motor neuron sign, that ultimately progression, so most likely this is ALS. So ALS demographics, and still it is male slight predominance. Peak onset is the 6th decade and 95% sporadic and 5% autosomal dominant. So there may be ALS diagnosis: upper motor neuron symptoms, loss of dexterity, slowed movement, loss of muscle stand, stiffness, and emotional lability. These are the features of upper motor neuron symptom. And ALS diagnosis in case of upper motor neuron sign, in case of cervical lesions, there is a pathological deep tendon reflex, Hoffman sign, and spasticity. In lumbosacral region, pathological deep tendon reflexes, that is exaggerated reflex, extensor plantar sign, and spasticity. In bulbar regions, there is a Georgia and other signs may be present, and thoracic loss of abdominal reflexes. So these are the upper motor neuron signs usually present in case of ALS. And lower motor neuron symptoms: loss of muscle stand, atrophy, fasciculation, and muscle cramps. So this is lower motor neuron. And sometimes familial amyotrophic lateral sclerosis may present, and this is autosomal dominant inheritance, variable penetrance, male female both equally affected, higher incidence of cognitive change. There may be chorea, younger onset, repeated. There may be a survival in 25% cases. There may be supraoxide dysbiosis involvement. And ALS plus syndrome. ALS plus syndrome, that means ALS, amyotrophic lateral sclerosis, is considered a degenerative disorder of the upper and lower motor neurons. However, some patients have all of the clinical features of ALS along with features of other disorders such as frontotemporal dementia, autonomic insufficiency, Parkinsonism, supranuclear Gales palsy, and or sensory loss. So if this ALS plus any one of these features, we call it ALS plus syndrome. And ALS, differential diagnosis. Differential diagnosis may be metabolic. We have to exclude the treatable cause of especially metabolic cause, hyperthyroidism, hyperparathyroidism, and sometimes paraneoplastic features may present with these same features. Lymphoma and small cell lung cancer, cervical spondylosis, toxin, especially lead or mercury toxin, and sometimes there may be enzyme deficiency and vitamin B12 deficiency, sometimes viral infection, especially post-polio, and multisystem degeneration, that is ALS-PD dementia or spinocerebellar degeneration, and paraproteinemia or bacterial infections sometimes may come in the differential diagnosis. And now come to the laboratory investigations. First, we will do all routine investigation, including CBC, urinary, blood sugar, renal function, chest X-ray, ECG. This should be all normal. Then come to the CK lab. Enzyme usually normal, muscle enzyme that usually normal, but maybe sometimes increased. And CSEP also will be normal, or sometimes mild protein elevation may present. And ALS electrodiagnosis, EMG, one of the important is to find fibrillation or fasciculation in two muscles in three extremity. In case of MND, there are three extremity: upper extremity, lower extremity, and head and paraspinal muscle count as another extremity here. This extremity is only for electrodiagnostic purpose, three extremity. And imaging, MRI of the brain and spinal cord is usually done to exclude any secondary structural causes, any secondary structural cause or any secondary changes. And in conclusion, although some patient with MND variant evolves in classical ALS over time, their clinical practice definitions may not be crucial, but recognition of the variant of the MND is sometimes. We come to the treatment issue to consider. That is symptomatic management, nutritional management, respiratory management, palliative care, therapy to slow the progression. There are no curative treatment. So we, as this is a neurodegenerative disease and no curable treatment is at all. So we give some symptomatic management, nutritional management, respiratory management, palliative care, and therapy to slow the progression. And symptom associated with MND, there may be dysarthria, dysphagia, sialorrhea. Sialorrhea means excessive salivation, emotional lability, depression, weight loss, bladder urgency, sleep dysfunction, constipation, edema, pain, spasticity, cramps, weight loss, fatigue, and weakness. In case of sialorrhea, symptoms result in inability to clear oropharyngeal secretion, and common pharmacological treatment are usually glycopyrrolate or amitriptyline. Here, amitriptyline is used. We know the side effect of amitriptyline is dryness of the mouth. This side effect used as a treatment purpose here, and sometimes suction meshing also used. So, management of emotional lability. Common pharmacological treatment are amitriptyline, usually 25 to 75 milligram may be used, and SSRI may use sometimes. And common non-pharmacological treatment, counseling, support groups. And in case of spasticity, common pharmacological treatment, muscle relaxant is used, baclofen, dantrolene sodium, tizanidine, diazepam, and sometimes botulinum toxin, that Botox, may use to treat the spasticity. And common non-pharmacological treatment, physiotherapy and occupational therapy. And management of weakness with assisted device, and we can use wheelchair and then cervical collar, hospital bed. It depends upon the patient requires. And management of dysphagia, One of the important complication of this patient are dysphagia. Here we considered PEG. PEG means percutaneous endoscopic gastrostomy. Usually on the settings of endoscopy, there is a percutaneous, there is in front of the abdominal wall and around the umbilicus there is a PEG টিউব থাকে, সেই টিউবটাকে ইনসার্ট করে দেওয়া হয়। সো কনসিডার কখন significant weight loss, inadequate fluid or calorie intake, difficulty swallowing medications, frequent choking during meal, prolonged meal time, and sometimes if there is a aspiration pneumonia or FEV less than 50%. And this does not prolong survival, but patient can take food. Malnutrition, independent factor for worse prognosis. Management of respiratory muscle weakness. Consider initiation of support when symptoms of nocturnal hypoventilation, FBC less than 50% of the predicted, and significant assessment of oxygen saturation. Drug treatment. There are no curable drug treatment, but there are supportive drugs used in MND, especially ALS in riluzole, IGF-1 growth factor, ceftriaxone, and coenzyme 10q10, statin, memantine with riluzole. This treatment sometimes used, but only definitive role has some is the riluzole one. It can only prolong the survival in case of ALS, but not in other cases. Riluzole. 3 separate mechanisms of riluzoles are thought to be reduce glutamate-induced excitotoxicity, inhibition of glutamic acid release, and non-competitive block of NMD receptor, and direct action on the voltage-dependent sodium channel. And prognosis. In case of ALS, prognosis is usually poor, and it depends upon which part is involvement. In prognosis, 50% patients die in case of 3 years. 20% can survive 5 years, 10% survive 10 years. And OS prognosis is bulbar onset, simultaneous arm-leg onset, and older age at diagnosis. That is, older age at diagnosis very high. These are the OS prognosis. So, if a patient, an elderly patient, came to you with slowly progressing weakness and worsening of the limbs or in the neck muscle or speech difficulty, you examine the patient and there is no symptoms of sensory symptoms, and there is no sensory impairment, no cerebellar impairment, no definite sensory level, no extraocular muscle involvement, no bowel bladder involvement. You find features of upper motor neuron lesions or lower motor neuron lesions or combination of the both. So most likely your diagnosis will be a motor neuron disease. আমি আবার বলছি, a elderly patient came to you with slowly progressive weakness and worsening, or maybe speech problem that is slowly and progressive and elderly. There is no symptoms of sensory symptoms, no bowel bladder involvement, no extraocular muscle involvement, no cerebellar involvement, and no definite sensory level. And you examine the patient, you may find the features of lower motor neuron sign or features of upper motor neuron sign or a combination, but no definite sensory level, no sensory sign. Your diagnosis will be motor neuron disease. And finally, thank you.
স্যার একটা কোয়েশ্চেন ছিল ওই চ্যাট বক্স থেকে। স্যার চ্যাট বক্স ছিল যে ইলেকট্রোএনসেফালোগ্রামে আপার মোটর নিউরন লেশন এবং লোয়ার মোটর নিউরন লেশনে কিরকম, মানে কোন সাইন পাওয়া যায়?
ইলেকট্রোডায়াগনোসিসে যেটা ইএমজি তে শুধুমাত্র লোয়ার মোটর নিউরনের ফিচার গুলো পাওয়া যায়, আপার মোটরের কোনো ফিচার্স ইএমজি তে পাওয়া যায় না।
থ্যাংক ইউ স্যার।
ওকে, এনি কোয়ারি?
স্যার চ্যাট বক্সে স্যার এইটা ছাড়া আর কোনো কোয়ারি দেখতে পাচ্ছি না স্যার।
ওকে, তাহলে আমরা এখানে শেষ করতে পারি।
আচ্ছা, ঠিক আছে স্যার।
Oh, thank
you
you
so much, sir, for just a great presentation. Assalamu alaikum, sir.
Okay. Thank you for inviting me, and thank you for your appreciation.
Thank you, sir.